10 questions. Let's go one by one. A patient of Parinaud syndrome. Parinaud syndrome, you should know, is affecting the dorsal midbrain. And dorsal midbrain contains a very important nucleus, a pretectal nucleus, which is involved in light reflex. So if the dorsal midbrain is affected, light reflex is absent, because light reflex, the afferent is optic nerve going to pretectal, then to Edinger Westphal both, and then via third nerve pupil constricts. So light reflex is absent, but accommodation reflex. When the near object comes, the light goes via LGP. As I told you, it's not a well-established pathway, but you can remember like this. It goes to visual cortex to see the near object. From there, directly Edinger Westphal is stimulated, and then the pupil is constricted. So pretectal is not included in, dorsal midbrain is not included in accommodation pathway. So pupil does not react to light, but react to near object. That is in Parinaud. That's seen in dorsal midbrain syndrome, like in neurosyphilis as well. Type 1 diabetes mellitus, myotonia dystrophy. These are examples of Argall trapezoidal pupil. Alright. The sign marked with the blue. So you can see this is the right retina. This is the optic disc. These are the retina blood vessels. These are small yellow shiny things, are hard exudates which are seen in outer plexiform layer. They are seen in, of course, diabetes mellitus, diabetic retinopathy. They can be seen in branch retinal vein occlusion, central retinal vein occlusion. They can be seen in sickle cell retinopathy. These are because of inner barrier break, the lipoproteins coming out. Central serous retinopathy is an example of outer barrier break, in which there is a fluid coming from choroid, but there is no hard exudates. That's the answer to this question. In terms of postoperative picture on slit lamp, you can see the arrow is marked. What is this? Something tube. Ceton surgery has been done. That is a glaucoma valve surgery has been done. So glaucoma valve surgery is usually done when there is a failed trabeculectomy surgery, when there is a severe conjunctival scarring, because if the trabeculectomy will fail if the conjunctiva, because the fluid has to go outside in subconjunctival space. If the conjunctiva is scarred, the trabeculectomy can fail. So severe conjunctival scarring like oculocycaturial pemphigoid, Stevens-Johnson syndrome, chemical injuries, glaucoma valve is usually preferred. Neovascular glaucoma is secondary glaucoma. So mostly neovascular glaucoma is also is not difficult to control, because there is a lot of scarring after trabeculectomy surgery. So faculatic glaucoma is due to hypermature cataract. So the cataract has to be removed. That is a prime thing in faculatic glaucoma, and of course under the control of intraocular pressure. But that is the main thing. Glaucoma valve implant in faculatic, that's not an indication. Alright. So this is the angiography of the right retina. The area marked in red is. Okay, what is this? There is a dye in the vessels which is leaking out in such a large thing, that is new vessels elsewhere. Some small dots are there, microisms, small dots. What is new vessels? New vessels are produced by VEGF, vascular endothelium growth factor, and VEGA, vascular endothelium growth factor, is produced by hypoxic retina. So all these hypofluorescence, which is dark, hypo is ischemic retina, which produces VEGF, which ultimately leads to new vessels in the elsewhere or on the optic disc. You can see a new vessel elsewhere over here. How the pre-retinal and subretinal hemorrhage is seen, new vessels and ischemic retina is of course seen in this image. I'll just show you. What can you see in this angiographic picture? Is this there is of course hemorrhage, that's why it's a dark, but is it pre or a subretinal? How can you find out? See, this is the retina vessel. If you see the retina vessel, of course, by some answer you can solve by English also. English mari achhi hai. So vessels are in front. Okay, these are retina vessels. So the hemorrhage has to be subretinal hemorrhage. This is subretinal hemorrhage. If there is a pre-retinal hemorrhage, of course you won't be able to see the retina as well. So this is your vitreous or a pre-retinal hemorrhage. So only by some English also, English words, you can answer some questions. This is vitreous hemorrhage, pre-retinal hemorrhage. Again, hypofluorescence. This is also hypo, subretinal hemorrhage. But how you differentiate? You can see the retina vessels. And of course, ischemic retina is this, forming new vessels. Wallenberg syndrome associated with Horner. So Horner syndrome can be associated with central preganglionic or postganglionic. Ganglion being superior cervical ganglion. Okay. When there is a, of course, then parasympathetic is not the answer. Wallenberg affects the central sympathetic pathway. From hypothalamus to C8, T1, T2, there is central pathway. So Wallenberg is the anatomomedullary syndrome. When there is a Horner syndrome associated, the central preganglionic fibers are affected. In preganglionic fibers are associated with apex of the lung. So there's a Pancoast tumor or a birth trauma or a chest trauma associated with preganglionic. And postganglionic, it passes through internal carotid artery. So patient has, which is in the cavernous sinus. So if the patient has internal carotid artery dissection or cavernous sinus syndrome, then or nasopharyngeal carcinoma, then there will be postganglionic. Sympathetic fibers will be involved. Alright, so here the answer was central sympathetic fibers. Optic nerve hypoplasia, as the name suggests, the optic nerve is small in size and the distance between the retina and the macula is usually 2 disc diopters. Here it is more than 3 disc diopters. It is associated with midline structural defect, absence of septum pellucidum, panhypopituitarism, not hyperpituitarism, so that's the answer. Can be seen in mother, baby of the mother who are taking some drugs like phenytoin, or the mother is a diabetic mother. The child can have central defects. In eye, there can be hypoplasia of the optic disc. There can be a double ring sign that is also seen in optic nerve hypoplasia. And if there is optic nerve hypoplasia, of course, blind spot will also be smaller, not enlarged. Please remember this. Where is the nucleus of the muscle mark? This muscle, superior oblique muscle, this is inferior oblique muscle. That is the answer here. Inferior oblique muscle is a simple question. If you identify, is a third nerve nucleus that is present in same side midbrain at the level of superior colliculus. Okay, please remember, superior rectus muscle has nucleus in contralateral midbrain, while superior oblique has again the nucleus in contralateral midbrain but inferior colliculus. Okay, so two muscles in the eye, SR and SO, will have contralateral nucleus supply. Third nerve supplies, rest of the muscle will supply the same. So third nerve nucleus is in midbrain. That's the answer at superior colliculus. Risk factors of development of posterior capsular opacification. What is posterior capsular opacification? This is intraocular lens. In the posterior chamber, you keep the intraocular lens. That's the ideal place. The epithelium then grows posteriorly. Why? Because of inflammation. So of course, if there is inflammation, there is high chances of PCO. So risk factors is uveitis. If there is retained lens matter, that will also induce inflammation. Younger people has more chances of getting inflammation after cataract surgery. These are the predisposing factors. Hydrophobic intraocular lens are better than hydrophilic. So that's the answer. It is not a risk factor. It is preventive. Also, when the lenses has a square edge, if the lenses have square edge, it prevents the epithelium to go backwards. And of course, what is the treatment? There is a laser capsulotomy by NDAC double frequency. Always say laser, photodisruptive laser, so that the light can go to the retina and the patient can see. It's the most common complication of cataract. Okay, the patient with thyroid eye disease was diagnosed after he presented with bilateral proptosis. Please remember, thyroid can have unilateral and bilateral proptosis. It's the most common cause in ophthalmology of unilateral and bilateral proptosis. Which of the following is not true? Please remember, this is not true. There is accumulation of glaucoma and glycan in orbital tissues. Of course, that's why the muscle and orbital tissues are swollen and pushes the eye out. There is lid lag present. Yes, there is lid retraction. There is lid lag present. Forced duction test. See, if the extraocular muscle is swollen and usually the belly is involved, it becomes restricted, fibrosed. So when you pull the muscle, there will be restriction. There is a restrictive myopathy. So forced duction test is positive. If the muscle is paralyzed, then freely you can move passively with the forceps. So in paralytic squint, for FDT is negative, while in restrictive, like in thyroid, FDT is positive. And if there is a restriction, for example, if there is a lateral rectus restriction, like you see over here, if this is lateral rectus which is getting restricted muscle, of course the patient will not be able to move his eye towards the opposite side. There will be a problem in adduction. If LR is paralyzed, then there will be problem in abduction. So that is the correct answer over here. That is an incorrect statement and that's the correct answer. There will be adduction defect when there is a fibrosis of LR. That's why when there is a fibrosis of IR, that's the most common muscle involved, patient has difficulty in looking up. Elevation will be a problem. Alright, so these are some points and this is a Werner classification in no specs that is seen in thyroid eye disease. The last question, doctor sees this sign. What is this sign? This is the iris pigments on the anterior lens capsule. It's a Vossius ring that is seen in blunt trauma. In blunt trauma, what is not seen, expect all the following except anglicization, lens subluxation and Berlin's edema causing cherry red spot is seen. Trabeculum eschwach pigmentation will be there if there is a foreign body going inside the eye. That is in penetrating trauma, not in blunt trauma. Okay. Other features in blunt trauma, there is ecchymosis, periorbital hematoma, there is subconjunctival hemorrhage as well. Then there is hyphema, iridodylisis causing a D-shaped pupil, washes thing, that is the answer. This is rosette cataract, Berlin's edema, inner layer ganglionic layer is involved causing Berlin edema. There is choroidal rupture, not an important sign but still choroidal rupture, and of course if you give your blunt trauma, there will be a fracture of the inferior wall of the orbit. Posterior middle aspect of maxillary is the weakest point of orbit, that is a blowout fracture causing a teardrop sign. Okay,